Hello, my name is Shannon Wallace from Stanford University Hospital in the United States, and I would like to thank the ICS for allowing us to present our work, a cost-effectiveness analysis of vaginal hysteropexy compared to vaginal hysterectomy with apical suspension for the treatment of pelvic organ prolapse. Our study was funded by a 2018 Foundation for Female Health Awareness grant. Here are our financial disclosures. Uterine-preserving hysteropexy for the treatment of uterine prolapse has become more popular in recent years. Studies suggest that vaginal hysteropexy has equivalent medium-term efficacy compared to traditional vaginal hysterectomy with apical suspension. Each surgical approach confers different risks and costs. Costs between uterine-sparing and traditional prolapse repair have not been compared. And so our objective in this study was to perform a cost-effectiveness analysis of hysteropexy versus vaginal hysterectomy with apical suspension for the treatment of uterine prolapse. We used Triage Pro software to construct a decision model tree comparing the cost-effectiveness of 4 surgical options: hysteropexy with sacrospinous ligament fixation, hysteropexy with uterosacral ligament suspension, vaginal hysterectomy with sacrospinous ligament fixation, and vaginal hysterectomy with uterosacral ligament suspension. We then determined the most cost-effective strategy. We modeled a population of healthy women undergoing surgery with a model time horizon of 1 year. We defined the health state utility values of prolapse, treatment efficacy, and the complications of each surgery. Utility scores ranges from 0 to 1, with 0 representing a health state equivalent to death and 1 representing perfect health. We derived utility scores from the utility scores calculated from the Pelvic Floor Disorders Network. These PFDN utility scores are based on responses to validated questionnaires and are used as generic index measures for health-related quality of life, and then used to calculate quality-adjusted life years, or QALYs. We calculated the expected number of QALYs for each strategy by taking a weighted average of the utility of each pathway in the tree and the proportion of the patient cohort who followed that pathway. We derived all probabilities from literature searches in PubMed and from the 2015 Dental-Nair randomized control trial of hysteropexy versus vaginal hysterectomy and apical suspension. Cost data was calculated from Stanford University Hospital institutional costs or extrapolated from cost-effectiveness literature. Cost-effectiveness was determined using the incremental cost-effectiveness ratio, or ICER, which is calculated by the difference in cost over the difference in effectiveness, or difference in QALYs. Strategies were considered dominated if they were both less effective and more expensive than another strategy. We also performed sensitivity analyses to determine whether changes in the model's input parameters altered the overall outcome of the cost-effectiveness model. In our model, sacrospinous hysteropexy was the most cost-effective strategy, followed by uterosacral hysteropexy, vaginal hysterectomy with sacrospinous ligament fixation, and then vaginal hysterectomy with uterosacral ligament suspension. With similar QALY measures between surgical options, both vaginal hysterectomies with apical suspensions were dominated strategies. We then performed sensitivity analyses on the cost of the different surgical strategies, as well as the recurrence rates and repeat surgery rates. When we varied the cost of the different strategies, vaginal hysterectomy strategies became the most cost-effective option when the cost of sacrospinous hysteropexy was greater than $50,000 and when the cost of uterosacral hysteropexy was greater than $49,500. Of note, vaginal hysterectomy with sacrospinous ligament suspension, which is represented by the yellow area in this graph, was more cost-effective than vaginal hysterectomy with uterosacral ligament suspension, which is labeled in green and does not appear on the graph. The driver for a more expensive uterosacral ligament procedure is the 1 to 3% risk of GU injury, which can lead to a repeat surgery costing about $50,000. Vaginal hysterectomy strategies, specifically with sacrospinous ligament fixation, became cost-effective along the curve shown in this graph. For example, vaginal hysterectomy strategies were more cost-effective when the recurrence rates of hysteropexy were 30% and 50% of these patients had repeat surgery, or when the recurrence rates of hysteropexy were 40% and 35% of these patients had repeat surgery. The major strength of our study was our use of published national data and data from randomized controlled trials. We also used sensitivity analyses to vary parameters. As with any cost-effectiveness model, we are limited by the availability of data and the accuracy of our assumptions. Additionally, internal institutional costs may vary for different institutions in the United States, as well as internationally. In conclusion, our study suggests that even if we assume higher rates of recurrence and repeat pelvic organ prolapse surgery, sacrospinous hysteropexy is the most cost-effective transvaginal surgical approach for the management of uterine prolapse. These results should only be used as a guide, as clinical decision-making should be comprehensive. Thank you for your attention, and I welcome any questions.